I think now we would like to switch the topic to JAK inhibitors. We were hoping that this talk would be given by Dr. Hermine Brunner, who has been closely involved with several clinical trials of these drugs in pediatrics. However, unfortunately, right this moment, she probably is presenting exactly the same slides to the investigators meeting in New York, and it's a start of a new clinical trial of JAK-STAT inhibitors in systemic juvenile idiopathic arthritis. It will be a phase 3 clinical trial. So in the meantime, I will try to walk you through some of her slides, and again, I apologize, I don't know this area very well. I'll do my best. I think you know that cytokines interact with cytokine receptors and signal through different intracellular pathways. There are quite a few of them. Perhaps the most relevant to the field of pediatric rheumatology are shown here, and I would like to make the point that JAK-STAT signaling pathway is just one of those. Relevant to our discussion today, cytokines like IL-1, IL-18, and IL-17 signal through a completely different set of pathways. Back to JAK-STAT signaling pathways. The main mechanism is shown here. Cytokines bind to their respective receptors. That leads to activation of tyrosine kinases and phosphorylation of the complex. Receptor complex, when it's phosphorylated, in turn then initiates recruitment and phosphorylation of STAT proteins. And phosphorylated STATs eventually translocate to the nucleus, and they activate a number of genes that are specific for a cytokine that actually triggered the signaling pathways at the very beginning. Now, there are quite a few JAKs, and they are involved with different cytokine receptors. Just to give you a couple of examples, if you look, again, I don't have a pointer, but if you look at the left side of this figure, you see that, for example, cytokines that utilize the common gamma chain in their receptor, they signal through mainly JAK1 and JAK3. Another example would be type 1 interferons. They signal through JAK1 and TYK2. IL-10 has a very similar signaling pathway. IL-6, which probably is very relevant to our discussion today, in general signals through JAK1. However, the signaling also seems to associate with TYK2 and JAK2. Another relevant cytokine, interferon gamma, signals mainly through JAK1 and JAK2. And then the IL-2 receptor family, they signal through JAK2 and TYK2. Now, if you come up, for example, with a JAK1 inhibitor, you see that the effects of such a drug would be rather complex and wide and would affect signaling through quite a few cytokines. And again, those cytokines are mainly on the left side of the panel. JAK2 inhibitors, again, would be covering quite a few cytokines as well, but again, the spectrum would be quite different. JAK3 inhibitor would be quite selective for the cytokines that utilize the... Oh, thank you, excellent. So, yes, well, it doesn't help that much, thank you. So anyway, the point is that sort of different inhibition of different JAKs obviously will lead to different biologic effects. Now, this slide lists some of the JAK inhibitors that are currently either approved or in phase 3 development. There are quite a few of them. Perhaps the most relevant to us at this stage is Tofacitinib at the bottom of this table. It's not very selective. It actually blocks the activity of JAK1, JAK3, and JAK2. It has been tried in various clinical trials and now has been officially approved by the FDA for the treatment of rheumatoid arthritis. And currently it's also in phase 3 development in psoriasis, ulcerative colitis, and now juvenile idiopathic arthritis, both polyarticular and systemic. Another drug that I think is very interesting is the one that is at the very top of the list, Tofacitinib. it blocks the activity of JAK1 and JAK2. Again, there is an ongoing phase 3 clinical trial in rheumatoid arthritis, but interestingly, it has been granted expanded access for patients with Candle and juvenile dermatomyositis as well as SAVI. And that is potentially relevant to our discussions today because many patients with those diseases, in fact, do develop interstitial lung disease. Many clinical features of interstitial lung disease that we see in those kids are very reminiscent to what we might see in patients with systemic juvenile idiopathic arthritis. Coming back again to the potential effects of JAK inhibitors, again, I would like to stress the point that the two that we are most interested in are shown on the right side. And again, if you look, they are expected to have a very broad effect on quite a few cytokines, including interferon gamma, IL-6, and also the cytokines that utilize the common gamma chain. Based on the experience with JAK inhibitors, mainly in rheumatoid arthritis, we are now learning quite a bit about the potential side effects. In addition to infections, we see actually quite a bit of laboratory abnormalities. And again, if you look at this table, there are differences between different JAK inhibitors, but there is a common theme. We see a significant decrease in the number of lymphocytes in many of these trials, true for lymphocytes and also for NK cells. We see significant neutropenia pretty much with all of these drugs. Significant thrombocytopenia, again, with most of these drugs. We see significant elevation of liver enzymes in about 10-15% of the patients. Another interesting side effects of JAK-STAT inhibitors is myopathy. Certainly CPK goes up in a substantial proportion of patients, and then we also see significant abnormalities in the lipid metabolism in these patients. And again, the final line in this particular table points the fact that it actually may be also toxic for the kidneys, and we do see levels of creatinine going up in a substantial proportion of these patients. So that's sort of what we see in general based on the clinical trials, mainly in adults. This slide summarizes the very first clinical trial of Tofa in children with juvenile idiopathic arthritis. It was a very small phase 1 trial. The primary objective of the trial was to report pharmacokinetics, safety, and taste acceptability of this drug in children following multiple oral doses. The age group was between 2 and 18 years, and all those patients had active juvenile idiopathic arthritis, and as far as I remember, those were mainly patients with polyarticular JIA. And again, the primary outcome measures were apparent oral clearance, frequency of treatment emergent adverse effects, lab test abnormalities, and clinically relevant vital signs abnormalities. It was an open-label, non-randomized trial. There were 3 cohorts of patients. Each included 8 patients, and those cohorts were formed based on the age. The first cohort included kids between 12 and 18, the second between 6 and 12, and the third cohort included patients between 2 and 6 years of age. Tofacitinib was administered twice daily for 5 days. At a dose of 5 milligram adult equivalent based on the body weight, and it was given either as a tablet or oral suspension. And overall, it was as you see, it was a relatively short study, so it was just a 5-day course of oral drug, and no serious adverse effects, in fact, were observed in the study. There were some minor effects, but again, sort of overall, the impression was that this stage is relatively safe. And that was the basis for these 2 phase 3 clinical trials that are starting right now, one in polyarticular JI and the other one in the systemic juvenile idiopathic arthritis. Just 2 more slides to show you some efficacy data of tofa in rheumatoid arthritis of adults. So here we're looking at the ACR 20 response. As you can see, the response rate actually is very high, even if you look at the patients who failed biologics and methotrexate. And just one more slide to show that, in fact, the use of these drugs, of tofa in particular, did slow down the radiologic progression of joint damage in patients with rheumatoid arthritis. And that's probably all I know about this drug, and what most of it I have learned from Hermine's slides. I know that quite a few people in this room have used JAK inhibitors for patients with systemic JIA and some other autoinflammatory syndrome. Can I ask you to share your experience? Yes, Scott.
Question. Oh. So, pardon me. Having worked near but not been contributing very much to the open label in interferonopathies that Rafaela Golbeck-Mansky's been running for quite a while, one of the biggest challenges with that study was that the drug levels achieved that was baricitinib, were really an order of magnitude less than expected in children than in adults, and that the metabolism, which is renal, was much, much more rapid than they had anticipated. And it's a very limited study, but I didn't know if the tofacitinib study had shown the same thing.
The only thing I know that, based on, again, I think it's confidential data that I don't have, but Hermine assured me that based on these initial studies, they actually know exactly what you do with tofa dosages in the phase 3 clinical trials. So I think there is data, I don't have it. And I think it's confidential at this stage.
So I have a question to the side effects. You showed that they were low NK cell. Do you know if there are any functional studies done on NK cell or T cells?
No, I don't think so, just numbers. Mm-hmm. So again, any clinical experience with tofa in our patient population? Grant, you have a patient, right? So I'll put you on the spot.
Yeah, so correct, right. We have a patient on ruxolitinib for SAVI, and I think I'd heard from Rafaela similar things, that in our BMT colleagues has recently published a paper on the use of ruxolitinib in chronic graft-versus-host disease in children, and actually had kind of a mixed experience. But again, these were very sick children who'd failed all conventional therapies. And the dosing for that and its FDA-approved indication is a twice daily, and Rafaela says they've had to move to 3 or 4 times daily in some of these patients, and I think that's sort of the road that we're moving in this child as well, who's actually a very young, brand new 1-year-old, who I think is one of the younger patients I've heard being treated with these medications. But he has been able to go down on his steroids and is tolerating it reasonably well without any side effects that we've heard of so far. I'm seeing him for follow-up in a couple weeks.
And the lung disease, did you have a chance to do some kind of follow-up study?
That's what we're going to see. So he's going to see both Chris Tao and myself in a couple weeks.
Fabrizio.
We have a patient with SAVI. We have a patient with SAVI, very similar to the one that Grant was describing. We weren't brave enough to go that very high with the dosage, to tell you the truth. Response is partially comes and goes. And I guess it's 6 months into treatment, 4 months, between 4 and 6. And the lung doesn't go spectacular, to tell you the truth.
And it's better
does not look spectacular.
It's not tofa, it's
ruxo.
Uh-huh.
I would ask Rafaela about the lung disease, because I think her experience in SAVI in a larger number of patients has been different. And I'll say that study is titrated to the interferon score, which not being quite as good as a phosphostat assay in cells, although I think she has data on that as well. They basically try to titrate the dose to the point at which the patient's interferon score normalizes, which may be a useful biomarker. I will say that in one of the more refractory patients that they had to push the dose on, they got into an issue with BK virus, not just in the urine but also in the blood, which was reported in a lot of the ruxolitinib studies as well. Well, it's that or steroids.
And I know there is a patient somewhere at Yale, I believe, who had systemic JIA, recurrent MAS, and lung disease, who was treated with Tofa, I believe, right? Anybody knows this patient? Anybody knows what happened long term?
Vivian may know better than I. I talked to, this is Ian Ferguson's patient at Yale. Was only on it for about 4 weeks, developed some neutropenia, and developed a skin abscess and stopped the drug, restarted it without, I think, any significant neutropenia, but then discontinued it because of a pneumonia that occurred without neutropenia. So not a very long exposure, maybe a total of, I don't know, 6 to 8 weeks. Is that about your...
Yeah, that's basically my understanding as well. That they started the medication. She did have this unusual abscess, and then they stopped it, restarted, and I believe she had pneumonia again. She continues to have advancing lung disease based on X-rays, and they've done various immune modulations.
Anybody else? Rahul?
So one of my partner's patient in Atlanta and Emory has failed multiple biologics, and we have tried Tofacitinib. Seems to be doing okay. No lung disease or MAS, but just refractory JIA, SJIA, and it seems to be somewhat comparable. And it like
comparable to what?
The other biologics. Most of the time, it seems like they all respond for a while and then they kind of plateau. So it seems to be earlier on.
And if you look specifically at the arthritic and the systemic components
Correct.
of the disease, do you see both components respond equally well, or you
Seems to be similar. I mean, this particular patient had more arthritic disease by the time. Systemic features were reasonably well controlled on Ilar and canakinumab, but persistent arthritis, so that was part of the reason for going on this. But at least tolerating, and at this point, I can actually find out more data and share with you.
In terms of dosing, what do you do?
Just kind of extrapolate, like 5 milligrams once a day. Or
So the same
like
what was done in the phase 1 trial. Yeah. Dirk?
If you are collecting single patients, we also have a patient on Tofacitinib with SAVI. She had some lung involvement actually before starting therapy, and that at least prevented any progression of that. Don't know if that is really due to the medication.
And sort of what time frame are we talking about here? For how long has she been on the treatment?
Almost 2 years now, I would say. Almost 2 years now. And she definitely had improvement of her skin phenotype and her vasculopathy, despite the fact that there was no real effect on interferon scores. So, but she had an effect on that.
And do you use it alone or in combination with other drugs?
Basically alone now. And she has...
When you say now, you use something else at the beginning, steroids?
She was on steroids, and before that on many anti-lupus drugs and so on. But she was on steroids, and we were able to taper that. And she has a very good response, I have to say, with her vasculopathy.
And in terms of safety monitoring, what are you doing in terms of safety monitoring?
The drug needed to be reduced because of first liver enzyme elevations, and then she's one of these patients Rafaela has with BK virus replication. And despite having any clinical symptoms, it was felt that the dosage needed to be decreased due to the liver enzyme elevation, some cytopenias, and then the BK virus replication.
So you think it's dose dependent?
I don't know if it's dose dependent, but at least it is now better controlled in a way. But we haven't tried systemic JA patients or MAS patients whatsoever. We are actually using on a research side JAK inhibitors in looking at monocyte differentiation and activation, and there we see that, I mean, you showed the specificity of these of the drugs. This is of course in a very, very narrow dose range, and so you can have effects that are clearly toxic already at dosages where you wouldn't expect it maybe. So it's certainly something we have to be aware of.
And Ed, could you please, sorry, there was another.
Yeah, so I know that Bianca Lang in Canada also had a systemic JA patient on Tofacitinib for a few months, and there was he had multiple biologics he failed, so anti-IL-1, anti-IL-6, anti-TNF, and he was off the anakinra and tocilizumab, and then changed to Tofacitinib for 3 months, and the systemic features flared again. So he was again on tocilizumab, but the systemic features went down, but the arthritis persisted, and this
So
is
it was
why
a dissociation between the arthritic and the systemic component.
he is the sixth patient on my poster on the left side. He was had the mesenchymal stromal cell administration, in fact, but he was on Tofacitinib in 2014-15.
Ed, I wanted to ask you about you've been involved with Kim Nichols in the JAK-STAT inhibitor study in animal models of HLH, correct? Yeah. So could you extrapolate some what you've learned there? Could we extrapolate some of the data on SJIA and MAS?
I'll try. The idea was, with the robust data about the central role of interferon gamma in familial HLH, that it would make sense to block JAK signaling. So in in the animal model, perforin-deficient mice getting LCMV infection, if you give those mice ruxolitinib, it was ruxolitinib, the animals do better as if they were getting interferon gamma blockade. So that sort of fit and made sense. And then to try and generalize, we did it in the so-called CPG TLR9 MAS model. It also worked there. Lane, do you have any of this data on your poster, or a little bit? Is it cool if I just talk about it? Okay. So the published data are that if you give the ruxolitinib to these CPG treated mice, they also get better. So in as much as you would want to extrapolate that animal model to human MAS, that's sort of interesting. But I don't want to spend a ton of time, but the data, when you look at them, don't make it clear that it's actually interferon gamma. That's the relevant cytokine here. It's probably more complicated than that. And to sort of make the long story short, going back to the monocyte comment, what we think is probably happening is that monocytes are critically important in these autoinflammatory MAS situations, particularly in the animal model. And what we think that the JAK inhibition is doing is preventing the generation of the monocytosis that's needed to drive the disease. And so it may be working in an interferon gamma independent way. So I think it's interesting, and I think the data are provocative and warrant further study actually in the human patient scenario, but it's probably going to be much more complex than just, we hit interferon gamma or we hit this one cytokine. It's going to be a systems immunology question.
Let me ask you about the dosing. If I remember when I read the paper, I remember your mice were getting 50 milligrams of the drug, right? So that 10 times more than adults in all these trials, because typically we would start with 5 milligrams, right? So what could you comment on that?
So the dosing we didn't actually choose the dose. That Kim Nichols really did the legwork on that, and it had something to do with other animal models in which the drug was being used and what was the appropriate sort of PK for mice, which is different than humans. So again, I don't know that I would want to draw too much of a strong correlation between the actual dose that's given to a mouse and what that means for the human beings. I mean, as we just heard, it's different in children versus adults, and so I don't want to extrapolate anything. Right, it came from another study, different than ours. So I think it's just, I don't know that it's comparable. I don't know that just because we gave the mice 10-fold dose that says anything about what dose it would take to achieve the same effect in human beings.
Yes, Fabrizio.
I'm also aware of 2 case reports that are in press using Ruxo to treat, I believe, MAS or secondary HLH. One patient did well. The other patient died, but got it late, like many, as you might expect. And they did show that there are improvement in some of the classic markers that we look at, like ferritin.
It was primary HLH or secondary?
These are, I think, both secondary. I don't remember because neither one is quite out yet. One is a Kim Nichols blood something, one of the blood spin-off journals. It might be. I can't remember. But they were HLH models, and so there are at least 2 case reports out there using Ruxo for this, where it may be of benefit.
I was just going to ask whether those of you who were implicating an effect on monocytes knew whether there was the effect on neutrophils might also be implicated in the animal models.
So we didn't see a direct change on neutrophils. It's really the monocyte lineage. Again, it's animal model, right? And so in as much as one wants to, I just try to be very careful about it, right? In as much as one can extrapolate from this TL9 model, it seems to be the monocyte lineage, yes.
What I can only say, because you also had the question about lung disease, and what I wanted to say with the data from the research side with using YAC inhibition on monocytes, we see that there are some dosages where you very effectively block interferon signaling, for example, but leave GM-CSF and some, let's say, hormone and cytokine or growth factor signaling open still. But this is a very tight, narrow range, so to say.
And actually,
if you get above that, then you also block GM-CSF signaling, and we are
very
interested
point.
in that.
Yeah.
And if you think about lung and alveolar macrophages and how much they depend on GM-CSF signaling, of course there's a narrow range, and especially when it comes to lung disease, you may, if you get too high, you may get adverse events actually.
Well, exactly right. So if you look at think about the primary alveolar proteinosis, it's either GM-CSF receptor mutations in the receptor or problems with the signaling. So technically, if we overdo it, we may induce some features of PAP.
But some reviewers are giving us a hard time because it's very simple data, basically simply showing how monocytes in culture react to certain concentrations of tofacitinib, and it's very simple phosphostat data and it's pretty clear, simple model, but we simply can't get that published.
Yes, Fabrizio, you've been.
Thank you, Ed. Hope you didn't hurt yourself. I know that at the Histiocyte Society there was a presentation from Michael Jordan from Cincinnati, so you must have seen the data, looking at Ruxo in periphery knockouts, and his data are pretty different from what has been published in terms of efficacy. Either at early time points or at late time points, certainly there is no therapeutic efficacy. And again, the dosing regimen was an issue. So I think this is, even in animal models, and I echoes Ed's saying, what animal models matter to us, but even in animal models, this is still very controversial to me.
That's a very good point. What I've learned from him is that when they used relatively reasonable doses, there was no effect. And when there was an effect, the animals started dying because of toxicity of the drug.
Yeah, that was my take, and the slides look pretty impressive to me in terms of no effect. But again, it's complicated. I'm sure it is.
It's not just the Kim Nichols paper, but there's also a separate report from the French group, and where right. So it's just. There's no easy answer except to say that I think that there's good rationale for why this does make sense, and there's, I think, enough data that there's probably something happening, and it may be more complex than just direct effects on interferon gamma. So keep the GM-CSF comment in mind, because I'm going to say something about that in a couple hours when I'm up there.
So again, not my data, but Rafael Gobekmansky's not here. So these are Rafael's data. But in the Candle-Salvi group, one of the concerns was these patients wouldn't grow because growth hormone signaling also is through a JAK-STAT pathway. And they have seen certainly growth. It's hard to say whether it's catch-up growth, but it certainly has not stunted the growth entirely in that population. I think in some of them they have a good 3, 4, 5 years of data.
But no, not all JAK inhibitors would affect the growth hormone signaling, correct? So should
If
we
you
also-
believe that they're selective,
Right.
which John O'Shea does not, who has the patent on tofacitinib. So at the doses we use pharmacologically, if you look at phosphostat signaling, they're not particularly selective.
Did you have a closing statement, Dr. Brown?
The more we know, the more anxious we are, right? That's the famous line. The knowledge generates more anxiety, that's what I'm saying.
It's a catch.